Thank you and welcome back. I think so far it's been really interesting, and I think I've learned an awful lot and keep learning, so that's good because every day's a learning day. So for the next session, I'd like to introduce Debra and Emma from the MSA Trust, and I'll let them carry on with their session. Thank you.
It's great. We've got the next 45 minutes to tell you a bit about MSA. We're going to do a double act. So I'm going to do the first 20 minutes covering what MSA is, how it's affecting the brain, getting the diagnosis and the prognosis. And then Emma will take over, and she's going to look at the autonomic symptoms in more depth and the symptom burden that this places on the patient and how we can manage those, and then touch on palliative care, end of life, and then we're going to tell you a little bit, I hope you've got some time, about the MSA Trust and how we can support health and social professionals and our patients and their families. So we'll have some time for questions at the end. Do make any notes, and we'll do our best to answer them at the end. We've got a stand at the back, so do come and say hello in the break, and we can discuss any more specific questions you might have about the patient. So what is MSA? It is a overproduction of the neuronal protein in the glial cells called alpha-synuclein. Now, these glial cells are really important because they support the neurons, and the alpha-synuclein helps with the synapse in the neurons and the neurotransmission. So it does a really important job. And an MSA is overproducing. So we have the messages then you're not getting through to the muscles, and we will see a degeneration and atrophy of these areas of the brain you see here. And patients will first present with either Parkinsonism features. It will affect the basal ganglia, which of course produces the dopamine, and we will see those early signs of Parkinsonism. Then we'll see in your patient the stiffness, slowness of movement, or they may present with cerebellar symptoms, and that will be more the coordination and reduced dexterity of movement. But they will all have a degree of autonomic disturbance because the brainstem is also affected in early disease. Of course, your brainstem houses your midbrain, pons and medulla, and that's all responsible for your autonomic system. So that's why we see these early autonomic symptoms. So it's categorized into two subtypes. If your patient presents with more of the balance and coordination difficulties, they will have MSA-C. And if they have more problems with the balance, rigidity, slowness of movement, it will be MSA-P. And it's estimated that around 80% have MSA-P and MSA-C in the Western Hemisphere. But they will all have autonomic disturbances early in their presentation. If they haven't got autonomic disturbances of both bladder, bowel, and blood pressure regulatory problems, they're very unlikely to have MSA. We would, of course, see those things later on in Parkinson's disease, but certainly not in early presentation. It's important to remember that as the disease progresses at different stages, however, as patients go through the course of their condition, they are all going to present with a mixture of cerebellar and Parkinsonism on top of the autonomic disturbances. So balance, speech, bladder, bowel, temperature regulation, breathing difficulties, swallowing difficulties, speech difficulties. So you can imagine how high the burden level is. We'll just remind ourselves with what the Parkinsonism patients may present to you with. They'll have that slowness of movement, that tremor that Dr. Butterworth mentioned this morning, which is more of a jerky tremor, a symmetrical tremor rather than you see in your patient with Parkinson's disease, where it will be unilateral, more rest tremor. They will have that difficulty, their mobility problems. And they'll have a poor response to your Parkinson's medication that you might be trying out to try and relieve these symptoms. We do try levodopa in the form of cinema or matapar in these patients. But we find that any benefit is very short-lived. Only about 30% actually get any benefit, and if they do, it's usually only for the first few years. So they won't get the wearing off that you see in your patient with Parkinson's disease later in their disease. So there's very little benefit of thinking about COMT inhibitors. We might use dopamine agonists such as ropinirole, pramipexole for early symptoms of restless legs, but using them as a dopamine agonist for their Parkinson's symptoms is usually not that beneficial, but you will see them used in some patients. The most important thing with this is to really do drug reviews and rationalisation of their medication. So they're just not left on this medication for years and years. We're limited with the dose titration, of course, because of the orthostatic hypotension we've heard mentioned in the other lectures. And that really limits our dose, but it is known that they can often, they're going to respond, they might respond to slightly higher doses, but that is usually poorly tolerated. So it's just a balance, really, of the side effects. And these patients can also experience dyskinesias. They won't be the limb dyskinesias you see so much in Parkinson's disease, but they're more cranio-facial dyskinesias, and they can be quite disabling, which is the last thing you want to add. Oh, that did it on its own. They'll experience earlier falls than you'd see in Parkinson's patients, and they'll experience this antichol, as we can see here, with this forward flexion of the head caused by the increased tone in the anterior cervical neck muscles. It can be really difficult to manage, and of course it adds to the quality of life as it compounds communication and, of course, eating and drinking further. And they have a generalised muscle weakness, and they will experience early falls. The cerebellar features, they'll have earlier speech difficulties. They'll be quite dysarthric, and they have the gait ataxia, and they have more difficulty early on with activities of living because of the coordination problems. And again, we see those early falls, which are red flags. So who gets MSA? It is rare, and patients will be typically diagnosed between the age of 50 and 70, so just the time when they're beginning to enjoy or plan their retirement and look forward to helping out with grandchildren. They get this devastating diagnosis landed in their lap, which has no treatment, no cure, and we can only tell them that we can help them manage their symptoms. Bear with me, I lost my voice at the weekend, so I stopped for more water to break. We never see it in anybody under 30, and it's rare to see it in the older person in their 8th decade. To put it into context, we know it's estimated that around 3,300 are diagnosed have MSA in the UK and Ireland, and that 500 of those will die each year from the condition. So the diagnosis, it's a great mimic, as we've seen, of Parkinson's disease and ataxia, and it can take around 3 years to get a diagnosis, which is a long time when you're dealing with such a progressive neurological condition. So we really want to get them reviewed regularly of the diagnosis. If you're identifying any red flags, such as those unexplained autonomic symptoms, there's a urinary urge incontinence, a neurogenic orthostatic hypotension, then we need a review, and regular review is extremely important. They will be sent off for an MRI scan to rule out any other neurological conditions, such as obviously normal pressure hydrocephalus, any space-occupying lesion, vascular changes. And you'll see here the classic hot cross bun sign. I haven't got a pointer, unfortunately, but see that on the brainstem there, which is here. The hot cross bun sign you'll often hear referred to, and that. If you have MSA, you will have it, but if you don't have MSA, if it doesn't come up on your MRI, you may also have MSA. And a further scan will often be done later on down the line, just as a comparison, and it will often show up later on in disease, but it's not fully diagnostic. It will be often sent off for a DAT scan. Often sent off for a DAT scan, and that will show as being abnormal in MSA and Parkinson's disease, and it won't differentiate between the two. So it's difficult to diagnose, and I've just put this up here to tell you that in 2022, I knew that the diagnostic criteria was revised to try and make it easier and to support clinicians to be more confident to deliver the diagnosis of MSA. And this has been really helpful. It's just looked at the 4 categories of MSA, and they are now categorized as neuropathological, where MSA can be diagnosed at post-mortem, probable MSA, or clinically definite MSA. And then we also established a cohort of patients who are ready for research that are presenting with those prodromal symptoms of smell loss and other symptoms very mild before they actually present with their cerebellar or their motor symptoms. So diagnosis is individual for each person, but we know that after 80%, after 5 years, 80% are going to be significantly disabled. Survival is around sort of 9 years, but we have had patients that survive beyond that, 12 years plus. The cause of death is often due to urinary or chest sepsis. These patients have a very low ventilatory tolerance and none or minimal chemoreceptive ability to pick up apnea at night. So desaturating. So it's often we have a few cases that have experienced sudden death. So it really tells you the importance of doing good holistic assessment and exploring the sleep problems. If they have a bed partner, get them to ask them how they've noticed any noisy breathing at night. If they sleep alone and they're waking up perhaps not so refreshed in the morning or waking up suddenly at night, get them to self-record their breathing and to share that with a specialist team. These patients can get into difficulties even with a tracheostomy, but if we can get them to an early sleep clinic and get thorough investigations and look at whether CPAP might be helpful, it can all help. So I've left this in, although it has slightly changed the diagnostic criteria along the bottom. It just gives you a good visual representation of the trajectory of this condition and what your patients are going to have to experience. And then you can see the prodromal symptoms I mentioned in the first patient walking, and then after sort of first year or so, they will start to show the Parkinsonism features, the cerebellar features. Before that time with the prodromal, they may have gone through several investigations, cardiac, respiratory, trying to find a cause for this before they eventually get to the neurologist. I think it will all depend really how vigilant their GP is, and also it's not uncommon for specialists that have come across to refer them to the neurologist, and they finally get their symptoms looked at properly and investigated. So we really can see how important it is for whole multidisciplinary team management here. These patients are best looked after under a rare conditions pathway by a nurse specialist or therapist in charge of that pathway, regular MDT discussion about their care. They should be having baseline neurophysio, neuro-OT and speech and language early on, and then revisiting that as they need to. And someone needs to coordinate that care very carefully and to be seeing them regularly. And you can see all the systems involved here that Emma will cover in a bit more detail, but the importance of that is vital. With continence team, respiratory, palliative care, so they can hospice referral, so they can start to benefit from day support therapy if you have that available, and then eventually they'll need palliative care team input. So, oh, that's you. All right. So the National Neurological Alliance Committee have devised these, developed these pathways for neurological adult conditions, and we have one here for MSA, which is really helpful, I think, for you to have a closer look at and just look at what's needed when for the patients. We've got copies of it at the back, and we've got it's available on our website. But it really helps you look at what you have available to you, how perhaps you could use your teams differently to get these patients a coordinated care so they're seen regularly by a professional that can actually help be their advocate for their care and support them and their families through the whole course of the condition. Right, so that's me. I feel I've flown through that with my hoarse voice here. I hope you've heard me okay. It's now a pleasure to hand over to Emma. If you want to have a stretch, stand up, feel free to do so. Before we carry on.
Thank you. Thanks, Deborah. I might stand here if you can hear me, just so I can see the slides, because there's no screen here. So autonomic symptoms are really difficult for people with MSA, mostly because there's an awful lot of them, and most of them have most of these symptoms. Early symptoms can start off with urogenital symptoms, so sexual dysfunction can be really early for men and women. It's often more obvious in men because it's erectile dysfunction, but women suffer from sexual dysfunction as well, and that's something they might need help with. And then they get urinary symptoms as well. They get all the urinary symptoms, unfortunately, so urgency, frequency, nocturia, retention. And what happens is they go to the doctor with these issues, and then men might have investigations for prostate issues, and women have investigations and treatment for pelvic floor issues or issues from childbirth. But actually what happens is the treatments that are normally successful for urinary issues don't work in these people, and that doesn't become obvious. The reason why doesn't become obvious for a few years until they get a diagnosis of MSA, and however further along the line they are. Lots of people with MSA suffer from postural hypertension. That's defined as a drop in blood pressure of those levels when people change position, most commonly when they go from lying down or sitting down to standing up. But really the numbers are a bit academic because we go on symptoms. We can see people who stand up and have a massive drop of sort of 40 to 50 millimoles and they don't have any symptoms. And then people can have quite a small drop in numbers but really quite disabling symptoms of postural hypertension. Those symptoms include mostly feeling dizzy and faint and passing out and falling. They might get blurred vision. They get coat hanger pain, so where a coat hanger would be in your clothes, where those big muscles are across the neck and shoulders, they don't get enough oxygen, so they get quite bad coat hanger pain, and it can lead to altered consciousness. So quite often people will say, oh, he just sort of like disappeared for a minute or two, or he just blanked out and didn't have any memory of it. So they can suffer from postural hypertension. It can also happen in places like in the bathroom if it's hot and steamy, or if they're straining on the toilet, that can drop the blood pressure as well, but I'll talk about that a bit further on later. And they suffer from constipation. It's been a bit of a theme today. I don't think a single talk hasn't touched on this yet, but in MSA they have the slow gut motility, reduced secretions, reduced sensation and the reduced muscle tone that's already been mentioned. So positioning and support is really important. So to be able to sort of be supported on the toilet and sitting well, to be able to open their bowels, that's really important when they're losing their sort of truncal control and ability to manage their muscles properly. Respiratory symptoms that Debra talked about. So people with MSA can get stridor, which is quite a distinctive breathing pattern. It's sort of like a really noisy, the vocal cords are obstructing the airway slightly. So when they breathe in, you hear the sound of the air rushing over those vocal cords, and it sort of sounds a bit like, is that right? So it's quite distinctive. and they have unintentional sighing, so they might be sighing all the time, but not knowing they're doing it. And then you get this noisy breathing and snoring as well. So noisy breathing in the day, really loud snoring at night. And they might not notice, so often asking their partner is a good idea, or asking them to record it. If they say that's happening, just say if you can record a video or an audio for your next appointment. So when the specialist sees you, they can actually hear it, they can hear that evidence, and they can make the appropriate referrals. And people get obstructive and central apnea as well. So obstructive apnea is those vocal cords lying over the airway that I've already spoken about. People can have a sleep study to see how they're getting enough oxygen overnight, and CPAP can help in these patients if they need it, to keep their oxygen levels up overnight to make sure they're well rested. But also people can get central apnea. So our respiratory drive is located in our brainstem, which we know is affected in MSA. It's part of our autonomic system, and quite often that central drive to breathe, sometimes that can be affected, and people are at risk of sudden death, unfortunately. Most commonly can happen overnight, and basically they just stop breathing and they slip away. It is rare, it doesn't happen very often, but it's quite important if people are sort of describing those apnea symptoms that we can support with CPAP. Central apnea, there isn't really a way of predicting if it might happen or preventing it happening. It's just one of those things, but it is quite rare. And people get problems with thermoregulation. So again, our body temperature control is located in the brainstem. And one chap said to me he went from a hot room, but it was a winter's night, out into the winter's night, and going from the hot to the cold temperature, he was really unwell. His body just couldn't cope with that change in temperature and regulate itself. Patients often start with saying they sweat a lot, and you get this in Parkinson's as well. People get changes with their skin, but lots and lots of sweating, and then actually they go on to eventually not sweat at all. We see that quite often. People will always say they've got really cold hands and feet and cold extremities, and they have a low base temperature anyway. So that's really important. So if you see somebody and they say, oh, I don't feel very well, or he's not himself, or I can't rouse them, and you phone the GP and say, I think there's an infection, can we have antibiotics? The first thing they'll say is, have they got a temperature? It's really important to know and to let your patients know that in MSA you may not get a temperature if you have an infection, or it might be that your baseline temperature is 35.5 or 36 anyway, so actually 37 is a temperature for those people. So it's a good idea to keep an eye on their baseline temperature, because that can be quite low. And then people will ask if vision problems, if eye problems are an issue, and they'll say they can't see, and they'll go to the opticians, and there's nothing wrong with their sight as such, but they might have, where their eyes are converging, those muscles aren't as sharp as they were, and they get blurred vision, or it might be due to the low blood pressure. Okay, that's the other button. There we go. So just to look at some of the symptoms, continence is an issue for most people. Actually, I was just going to go back to that slide. Where I've put ask, as you can imagine, it's often the movement symptoms that bring people to the doctor. So the family member saying, "Oh, you're really slow," or you're bouncing off the walls as you walk down the corridor, go and see a doctor. And these are early symptoms, like urogenital symptoms, especially constipation. I say ask because they won't volunteer that information. Because if you say, "Oh, you're constipated," they'll go, "Oh yeah, but I've had that. I've always been constipated. It's not related. I've had constipation for the last 10 years." Or of course, the sexual dysfunctional bladder issues. They'll say, "Oh yes, I've had that. I've had treatment. It didn't work." So make sure that you ask them, because people often won't offer that information because they won't have made that link themselves, but it helps build up the picture. So speech and swallow. I am just pressing it once. So speech and swallow issues. These are really common to all the neurological conditions. So you'll be experts in these. I won't dwell on them. But we see the usual speech difficulties. People with MSA can have an ataxic voice, or a really sort of high-pitched voice, or they often lose the volume, so they go very, very quiet. Or they can struggle to coordinate breathing and speaking, so they'll sort of take a deep breath in, get all their words out, and then need to breathe again. And actually, we need to prepare them for complete loss of sound production, because often they can lose their voice completely in MSA. So the therapy teams are obviously excellent at supporting with that, and we do fund voice banking. I won't dwell on that either, but we are at the back, so if you do have any specific questions, just come and talk to me and Debra. But we can fund voice banking through the Speak Unique programme. And I've already spoken about the vocal cord paralysis stridor. We do need to talk to people about this, because although the sudden death in the stridor is a bit more rare, it can be a medical emergency. So, you know, if your airway blocks off completely, to survive that, if it doesn't resolve, often it can happen and it can resolve. But if it's not resolving, the only treatment for that is a tracheostomy. And it's kind of important to know if somebody would want that with a progressive neurological condition. So that plays into advanced care planning that I'm going to talk about. But it's really, really rare. But actually, tracheostomy has big implications, often for where people can receive care, or for how they might want their condition managed. So you can imagine if that's something you wouldn't want, it's really important that that doesn't happen. And it's a difficult conversation to have with people. So swallowing difficulties are the usual ones that we get with any neurological condition, and management is exactly the same. So it's feeding into your MDT and getting them that excellent support that the therapy teams can offer. So therefore, refer to speech and language early. Equipment can be useful. So obviously there's lots of high-tech things around. Amplifiers are good because they lose their volume quite early with MSA. We do have some light writers that we loan out, although things have moved on a bit more from that. Then obviously you've got your speech, voice banking and speech apps. Actually, low tech are quite good, really, really good as well. So picture boards, alphabet charts, commonly used phrases. I encourage people to use them before it's the sort of thing they'll put off and say, oh, I don't need it yet, but actually getting used to them before you need them. Or, you know, if your voice is good in the morning, that's great. And if it's more difficult in the afternoon as you fatigue, it's a good time to start using them. Managing saliva, so eye drops, Botox for drooling. There's sort of a ladder of treatment we can work our way through. Dietitian, I think I'm not going to dwell on that because you've already heard what an excellent service that's provided near here. And then obviously that feeds into the nutrition team as well, and considering a PEG before marked weight loss, which again people will just put off. They need to know that actually it doesn't mean they can't have anything by mouth. People will say, if I can't have a cup of tea, my life isn't worth living, which I think is reasonable. But when you can explain to people they can have a PEG and a cup of tea, or it's just, as Cara said, making sure they get all that information to make an informed decision. So mobility, refer to physio and occupational therapy early. So there's often specific problems like turning in bed, initiating movement. You don't want them getting out of bed too quickly in the morning if their blood pressure's dropped overnight, so they might need to stay in bed, drink a glass of water, do some exercises, some calf pump exercises to get the blood pressure up. Planning for wheelchair dependency and hoist transfers, and then getting the right chair and wheelchair, so reclining or tilting spaces can be really good for people with MSA, because if their blood pressure drops, we can recline them. And that anti-collars that Debra touched on, so head support collars, massage, heat packs, and Botox if needed. So other symptoms that people get, put down. Emotional lability, so extreme laughing or crying, or extreme emotional responses, or inappropriate. So if something is funny, they might cry, and if something is sad, they might laugh. And the thing is, people have an insight that that isn't appropriate, but they can't explain why they're doing it. Like one chap, for example, he said he went to his friend's funeral and he started laughing, and of course you can imagine how that made him feel. We've got a fact sheet and some tips of how to manage it and things that can help, but explaining to people that it's part of the condition, and explaining to their partners, and they'll go, oh, he was doing this and it was just awful, and I can't understand it, it's not like him. But explaining to their partner, actually it's part of the condition, this is why it's happening, this is, having that understanding sometimes, even if we can't necessarily take the symptom away, but helping them understand it's part of the condition can be really important. People do have sleep issues, so restless legs and discomfort, for which reticulotin patch can help. Parkinson's drugs, as Debra mentioned, they get all that nocturia, so often because of the low blood pressure, the kidneys aren't well perfused in the day, so when they lie down at night, their blood pressure goes up, the kidneys get a bit better perfused, they start kicking out urine. We see that in Parkinson's as well. But then if people aren't sleeping well, or they stand up at night, their blood pressure drops, they're at risk of falls, all feeds into each other, and it can be really difficult. So a really important one to manage. Medications can help, as can catheterization. We've spoken about sleep apnea. They get the vivid dreams and the REM sleep disorder that we've spoken about. So even if they can't move well in the day, you'd be amazed. They can hop out of bed. They think they're playing for England's first 15, and they're beating up their partner, who then the patient doesn't believe them the next day. So that's something we can manage. That's a symptom we can manage. So again, it's one to ask about because they might not have made the link that it can happen. In terms of cognition, we don't really see dementia in MSA, although actually I am seeing more people who sort of having more cognitive issues or getting two diagnoses at the same time, because it's hard to know exactly what's going on in the brain. But traditionally we say people with MSA don't get the frank memory problems you might expect, but we do see that people can have executive functioning disorder. They can't learn new things, they get sort of rigidity of thought, they can't retain new information. It can be really individual for people. And people get cognitive slowing, so you kind of need to slow down the conversation, talk about one thing at a time, give people time to respond. And anxiety and depression we know already is part of these conditions. Must know it's near lunchtime. Okay, so specialist equipment. It's basically anything that helps people manage their activities of daily living and keeping up their independence. And I think there's a lot of therapists in the room, so I won't dwell on it because you are the experts. What we would do is just say we need to get those therapy teams involved. People can find it frustrating if they're referred and an issue is dealt with and then they're discharged and then they have to be re-referred again if there's another issue. Therapy teams tell us they want to see people early, so when something starts to become an issue, get them referred in. We tell that to our patients, but they will constantly go, oh, it's not too bad, and they will leave it almost until it's too late. So just trying to have those ongoing reviews and encouraging them to get in touch if there's a problem is really important. And then palliative care. I don't know how I'm doing for time, but MSA is a palliative condition, unfortunately, but it happens to young people. Nobody expects it. Certainly nobody wants it. Nobody's ever heard of it. It can take them a long time to get a diagnosis. There's an awful lot going on and an awful lot to try and get your head around. And then on top of that, if we jump in with mentioning the word palliative care, about which there's still a lot of misunderstanding, it can be really difficult. So we talk about it being about living well and quality of life, and certainly not just end of life care. Early referral can work really well for people. And things that people might want to consider when we think about palliative care are things like advanced care planning. So knowing what might happen, knowing what your choices might be at that point in time, communicating those choices to your friends and family. We've already spoken about how communication becomes more difficult, so we want to plan these, talk about these things in good time while someone is still able to communicate their preferences. Those preferences feed into their choice, obviously, and quality of life. So things like how a peg might not extend your life, but it might improve your quality of life. Is that something you would want? Is that something you wouldn't want at all? The support the hospice can offer, so that holistic support. So actually, it might be about having a bath. It might be about having your nails painted. It might be about going there so that your partner can have a couple of hours to themselves. It might be about the fact that a lady said she really likes going out for coffee and cake, but she doesn't like doing that in Costa, but she feels she can go to the hospice cafe and have good cake and coffee because she feels like nobody's going to look at her there. Respite care is difficult to get. It needs to be revised, that slide, but obviously they can offer day respite and signpost to other services. They can really help with symptom control. And then that holistic counselling, emotional, psychological support, carer support, family support, all those things that we don't always have time to do in our medical appointments, no matter how much we'd like to, is explaining to people that that's what palliative care is and how to access it. And part of that is advanced care planning, which we encourage so much, but it's still something that can be really difficult to get in place well and in good time. So raising the awareness of what it is and getting it in place early. These are complex issues. It's never a one-stop conversation. You want to sort of raise the issue, give the information, give people time to think about it, come back to it. It can be difficult. People often might not want to have that conversation in the clinic room with their family member, and you can guarantee if clinic's on a Tuesday, by Wednesday afternoon I've had a phone call saying I didn't want to ask in front of they never want to ask the doctor, or they never want to ask in front of their family member. And sometimes that's difficult if that's a cold, you're answering the phone cold and that's a cold conversation. they'll ask those prognosis questions: how long have I got, and when will I die, and how will I die? And you're like, well, hi, my name's Emma, can we take it back? Can you tell me your name? So there's difficult conversations, and actually they might not want to have that with their family, so having a professional to talk these things through can help. And there's conflicts as well about expectations of what can be done and what should be done, and what some people want and what their family don't want. But end of life issues, palliative issues, it's important to raise it early, not to get it all sorted and written down and put away in a box, but just because we can start these conversations, and we know communication's affected, so it's important to, if someone feels they're able to communicate their wishes, and then getting them known to the family and the medical team. Typical things to talk about: would they want to be resuscitated? Do they have any advance directives? Would they want a PEG? Do they want treatment, admission to hospital? Brain donation, actually, we've spoken about how these conditions can really only be diagnosed by looking at the brain under a microscope. And even in the best centres, when you match the clinical diagnosis to the brain at post-mortem, it's about 86% accuracy for things like MSA and PSP. There's a lot of research that goes on in these brains, and there are brain banks all over the UK, but there's specifically an MSA one at Queen Square. They do an awful lot of research into MSA, so people with MSA might often want to donate their brain, which is an amazing gift. It is an absolutely incredible gift, but it's something, again, that we kind of need to talk about in life, get the information to them, get their consent, get the paperwork sorted, talk them through the process. So actually when somebody sadly does pass away, we need to make every effort to meet their wishes. So if they've wanted to donate their brain, it's not always possible for us to make that happen, but it's certainly possible for us to try our best to make that happen. And there's just things that need to happen around that, so making everyone aware at the time. For example, I went to see a chap in a hospice on a Friday afternoon on a bank holiday weekend, so and he was really keen to get his brain donated, so it was just making the staff aware what needed to happen, how we can plan for that to try and get those wishes made. Did you want to do this one, Deborah, or shall I? Yeah, carry on. So key takeaway notes: you'll be sick of my voice, but multidisciplinary team approach is preferable. People with them, we do a needs survey of our members every couple of years, and the two things that always come out are lack of emotional support and lack of care coordination. So care coordination, care services, they vary massively. We're a national service, so they vary massively up and down the country. There's one particular place in the country that's in my patch where I will get a phone call and they'll say, oh, the doctor told me I had MSA, they told me there was nothing they can do and they discharged me. Can you tell me what MSA is? And that's really difficult. A, there is things that we can do, and B, they shouldn't be bringing me to, that's a really difficult conversation, and they just don't get enough support, really. And then other people are really well supported up and down the country, and that's really the involvement of the MDT, the nurses and the therapists, and palliative care. I didn't touch that this morning. Okay, so as Deborah said, regular medication rationalisation, because they do progress really, really quickly, and what was appropriate and the best treatment we could offer 6 months ago might be different in 6 months' time. Ideally, we'd like them to be seen every 6 months by their doctor, every 6 months by a specialist nurse, alternating, so they're seen every 3 months, but obviously that rarely happens because of constraints in our services. There is early discussions around MSA. These people have waited a long time for a diagnosis often, and then you kind of want to touch on all the issues that are important to talk about, but it's hard to know when exactly to do that. Observe for red flags and provisional PD, ataxia or other diagnosis. If actually you're seeing somebody and you think, this isn't, those red flags are popping out and you don't think it's what they said, please do raise those. You rarely would be wrong. And early clinical assessment and treatment of decline in MSA, so we can do what we can when we can, rather than it being too late. Just a bit about us, if I've got time. This is our map. There are 6 healthcare professionals for England, Ireland, Wales and Scotland, the Isle of Man. And our names there, our maps there. Please get in touch at any time. We are normally on the phone or via email. If we're not, it's because we're somewhere like this or we're in clinic. Please just leave a message. We do specialist clinics, so we do attend clinics around the country where clinicians have sort of organise our atypical clinics, and we're invited along, and we have honorary contracts. We offer voice banking support, we do teaching and awareness sessions. We're here to support healthcare professionals who may not have too much contact with people with MSA. And we're the HCPs, but we've also got a social welfare specialist team of 2 people, or 1.5 people, and they can deal with non-medical support. So again, these are young people, they're normally working, they can talk about benefits, entitlements, care support, anything like that. And that's our website. Encourage people to join us. We're not an NHS service, so people have to register with us just so we've got their permission to contact them. That's doing that. So it's telling me that you're ready for lunch. To contact, so encourage them to register with us. Sometimes even if you give them a leaflet, that they think that means they're registered, but encourage them to come and join us. We have fact sheets for common symptoms. We have professional guides for you guys if you're seeing people. We're a really tiny team, so we try and be responsive. We offer support for patients, so we do online support groups, face-to-face support groups. There's an online forum, there's a social media channel where they can get that peer support from other people. We have webinars, which are just video format, so not everyone likes written information. We have webinars for people who are newly diagnosed, blood pressure management and palliative care. We fund voice banking. We have a really small grants budget, so if you're struggling to get something for someone that isn't available on the NHS, get in touch. I've not really touched on this, but we offer emotional support. We have got a good document we developed during lockdown. You can come and see us, we can talk you through that. And we also have a collaboration with Rare Minds, who are a counselling service for people with rare disease. So talk to us about that. People will ask about research, about clinical trials. Again, encourage them to register with us, point them in the direction of our website. We have a research hub. There are clinical trials ongoing at the minute, so talk to us about that. And then on the right, I've just put just a screenshot of an article that came out last year in the Journal of Practical Neurology, but it's called Multiple System Atrophy, but it is an absolutely fantastic clinical guide to investigations, treatment, what can be done. So I always, if you're seeing people, I point you towards that guide, because that's a complete package for how to manage patients. And I'm sorry if I ran over, but there's further reading. And there you go. Thank you.
Thank you, Emma and Debra. Any questions?
Yeah. Are you a chargeable service? No. So everything
Does that mean we charge? No. All of our documents, resources, access. No.
So what about your face-to-face meetings with the patient? Are they free as well when you do support groups?
Yeah.
Okay.
Yeah. No, we would never want to constrain people. We don't get any funding, and people do donate or do fundraising, but you don't have to. That's completely separate to our services.
Like a charity.
Just a shameless plug, we've got a Planning Your Care in Advance document in Milton Keynes where we promote advanced care planning, and that also has a section on brain donation in there. And the other thing also to mention, we talk about sort of support for the rarer conditions. In conjunction with the Will and Wellbeing Centre, I'm looking at Emma there, you can bombard her as well. Just started a rarer neuro drop-in, which is the first Friday of each month from 1 till 2:30 for NMD, MSA, PSP, CBD. So that's been running for about 5-6 months. So that's something for people with the condition and their relatives, friends. It's been really, really well attended. So there's 2 things. So that's my plug. Any other questions? Sorry.